And in the past, you've learned ABGs, you've learned fairly simple ABGs. And I think what you were asked to do in the past was simply to identify what's going on. Well, that doesn't really matter. So we want to know what you're going to do about it, and how specifically the ventilator can change and things like that about the patient. So being able to assess that a patient is in respiratory acidosis, okay, we can teach anybody to do that. Here's what you know. So we're going to talk a little bit more about it, and we're also going to add an extra thing, because you talked about this respiratory acidosis, metabolic alkalosis, whatever, but we're going to assess if it's either compensated or uncompensated. And that is not as easy as you might think, but I think I've made it as easy as possible to figure out what's going on with that. But just to review what an ABG measures. So on the ABG, here's are the numbers that you're going to get, right? Your pH, your PCO2. And if I say PCO2, it's the same as PaCO2. PCO2 is easier to say than type. Same thing, like partial pressure of carbon dioxide in the blood. PO2, the sodium bicarbonate, the base excess, and the O2 saturation. You get a perfect O2 sat from an ABG. So remember that usually the way that an ABG is obtained is through sticking an artery. And in most facilities that you will work, the person that is responsible for this is the respiratory therapist. If you have been trained, and that is your facility's policy, that RNs draw ABGs, you can do that. But generally it's the respiratory therapist. At the Med until several years ago, it was the nurses that drew the ABGs, but now the RTs do it, thank goodness. So usually it's in the arm, in the radial arteries where it's stuck. If the patient has decreased perfusion or has not a good radial artery because it's been stuck 150 times, the patient can be stuck in the femoral artery, and usually that's done by a physician. Be aware of what the Allen's test is. If you want to practice it on somebody next to you now, you can. But what you do is that whichever arm is going to be stuck, you occlude the radial artery and you occlude the ulnar artery. So you push down really hard, and the hand will get pale, right? Because it's not getting blood. Right? So if you're going to stick the radial artery, you want to make sure that the ulnar artery can take over if something happens to that radial artery when you stick it, right? So when you release the ulnar side, keeping the radial side occluded, the hand should turn to pink, right? That's so that the ulnar artery can perfuse the hand if you obliterate the radial artery, all right? That's the Allen's test. If there's any respiratory therapists in here, I hope I described that right, right? Anytime that an artery is stuck, as opposed to, or in comparison to a vein, the patient is at higher risk for bleeding, right? Why? More pressure, right? So, of course, the patient will need a pressure bandage, and you want to hold pressure for a minute or two to that site. Even if the patient does not have coagulation disorders, you still hold pressure for at least a minute or two. If they do have coagulation disorders, you might have to hold pressure for even longer, meaning PTTI. Right? Several of you have seen these art lines. They're fantastic, right? So you can do anything with an art line, draw any blood from it, but specifically an ABG. This is we've talked about it a little bit. This is that catheter inside of an artery that gives us a real-time, continuous, perfect blood pressure. So the RN certainly can do this, especially at the Med, but some facilities still want the respiratory therapist to even draw the blood gas from the art line. You want to document on the sample, on the slip, the temperature, the patient's temperature, because then it can affect the patient's pH. You want to document the patient's FiO2. Why? Because we want to compare the PO2 to what the FiO2 is. And it should be taken to the lab immediately. Walk to the lab, not tubed in the tube station, in the tube system, and it should be on ice. Right?
The ABG waveform, is it the arterial blood pressure?
Right. Yeah. Because if the waveform is not looking good, that line might become occluded or kinked or something, and that just warrants further assessment. And maybe you shouldn't be using that line, and we might need to adjust it or something first. Okay. So this is what you're still haven't updated this. Is that still chapter 10?
Yeah.
Okay, good. Edition 5. Right. So this is probably what you're used to, just being able to identify these three things on an ABG. And that's certainly the bulk of evaluating an ABG. So I'm not going to read the chart to you, but you see that, a low pH is acidosis, a higher pH is alkalosis. Keep in mind that PCO2, that carbon dioxide, is an acid. Carbon dioxide equals acid. Sodium bicarbonate equals base, right? Here are your normal ranges. Realize that in your facility, whether you're at Methodist or if you're at the Med, these numbers might be a little bit different. You're going to find that in practice, different labs measure things differently. So when you're in clinical and in practice, you will certainly go by what your facility says is the normal range. But for us, these are the normal ranges, okay? And it's easy, right? Because they're both 35 to 45 for pH and PCO2, by 22, 26, right? So let's talk about how to evaluate an ABG a little bit more advanced than what you're used to. So with an ABG, every ABG has a first name, a middle name, and a last name. Right? The first name is either compensated or uncompensated. The middle name is respiratory or metabolic. And the last name is acidosis or alkalosis. So the pH tells us about the what? First name and the last name, right? So the first name simply is compensated or uncompensated. The pH tells us that. So if the pH is normal, it's compensated. If the pH is abnormal, it's uncompensated. That's simple, right? And the pH also tells us the last name. The last name simply is acidosis or alkalosis. But just remember, if it's lower, it's acidosis. If it's higher, it's alkalosis. But we'll talk more specifically about these numbers here. And the middle name is either metabolic or respiratory, but what's going to tell you about that is the PCO2 and the sodium bicarbonate, right? So if the PCO2 is causing the problem, it's what? Respiratory. If the bicarb is causing the problem, it's what? Metabolic. Okay? When the patient is compensated, this one is, you're used to uncompensated blood gases, right? So you can quickly look at it. Okay, it's less than 3.45, that's acidosis, period, right? But when the blood gas is compensated, that means that the pH is normal. So you're saying, well, how am I supposed to know? Well, then you look at the midpoint. The midpoint is 7.4. So if it's less than 7.4, it's closer to acidosis. If it's greater than 7.4, that's closer to alkalosis. Does that make sense?
We were wondering if it landed right on some.
I will never give you a question.
Okay.
Okay. Right? You can still figure it out, but I won't do that. It's 7.39, 7.41. Right? Did I miss a slide?
No.
We need to look at this. So this is just a nice little picture for you. So this is the normal range for a pH 7.35 to 7.45. Just think about this triangle. If you get your test and you want to write this on there, certainly probably will be a good thing to do. 7.4 is the middle point. So anything over here is acidotic. Anything over here is alkalotic, right? For the compensated. Yeah, because if it were uncompensated, it would just be less than 7.35 or greater than 7.45. Right. So let's just go through some of these. On ABG1, what is this ABG's first name? Uncompensated. Why? The pH is abnormal. Right? What's the ABG's last name? Acidosis. Why? pH is low. Right? But then you say, which one of these is causing acidosis? Which is causing acidosis? Is it a deficient bicarb or is it a deficient PCO2? The deficient bicarb, yeah. So if you don't have enough base, you're going to end up what? Acidotic, right? If you don't have enough acid, you're going to end up alkalotic. So what's the problem here? Metabolic. Right? The low bicarb is causing the acidosis, right? First name on ABG2? First name. Uncompensated. because the pH is abnormal. What's the last name? Alkalosis because the pH is high. Which of these is causing alkalosis?
It's going to be your
Metabolic, right? Because the PCO2 here is normal, yeah. Okay. First name on ABG3, uncompensated. Last name is what? Alkalosis because it's high. Which of these is causing alkalosis? A deficient base would cause alkalosis? That's a contradiction, right? A deficient acid would cause alkalosis, right? Not enough acid, you're going to end up basic, right? Yes, ma'am.
So when they're both out, you're determining which one it is because the carbon dioxide would not be, because they're backwards basically. The acidosis is that.
Some people aren't that way. I don't. But yes. What do they say? Acidosis opposite, or respiratory opposite, metabolic equal. The same. Is that what you're asking?
Kind of.
Yeah.
How did you learn it? Yeah. What were you just saying?
I learned it simply by saying that which of these would cause acidosis or alkalosis. So I just think that a deficient base causes acidosis. An excess base causes what? Alkalosis. A deficient acid causes what? Alkalosis. An excess acid causes what? Acidosis. You just have to get in your brain that carbon dioxide is acid and that HCO3 is a base. So too much base, you're basic. Too much acid, you're acidotic. Not enough acid, you're basic. Not enough base, you're acid, right? I'd say one of those backwards, but whatever. Right? All right, so keep in mind this here when we look at the next one. So ABG4, the first name is what? Compensated. Why? pH is normal. pH is normal. Okay. And what is the last name? Alkalosis, because it's greater than 7.4. All right. Which of these causes an alkalotic problem?
respiratory.
Respiratory. Right? Because you have a deficient acid. Your acid is low. What has happened here is that because there was an acidotic, let me start over. They're alkalotic, so the deficient acid, right? And the bicarb is attempting to compensate. It's compensating, or it has compensated, because it's lowering the acid, or lowering the base. Does that make sense? We were in an alkalotic problem, so the bicarb started to fall to compensate for the deficient acid. Because your body wants to be, or it has to be, 7.35, 7.45 to normal function. Let's look at the next one. First name is compensated, and it is, what's the last name? Acidosis, because it's closer to, or it's less than 7.4. Which of these here would cause an acidotic problem? Which would cause an acidotic problem? A high acid, right? So it's respiratory, right? So compensated respiratory acidosis, right? What about this one? Compensated. Last name is acidosis. Okay, so now the hard part. Which one causes acidosis? The bicarb is causing acidosis because the base is too low, so we're going to end up in an acidotic state. Right? So this is compensated metabolic acidosis. Right? So, do some more examples of that, but having said all that, this will be a very, very low percentage of the test question. Right? Because it's like, okay, so what? Right? So you can read an ABG. How are you going to take care of the patients? What's most important? So here's a practice question. Patient is in respiratory failure. We'll talk more about that in a few. They're on the vent, and here's the blood gas. what should be done to fix this blood gas? Well, right? But what you have to say is, which of these is abnormal, really? So let's just go through them individually. Okay, the pH is too low. The patient is, looks like here they're just in straightforward respiratory acidosis. But the biocarb is normal, so cross it out. The pH is it's abnormal, but the PO2 is what? Normal. Cross it out. Right? So what do we need to fix here in order to make the patient's pH come into normal range? We need to fix the PCO2, right? So how can we get this PCO2 down? Would we increase the Versed? Because what would happen then? The patient would breathe less, so the patient would have even more rise in PCO2. Would we give them sodium bicarbonate?
No.
We could, but that's going to, number one, temporarily fix the problem, and the biocarb is normal, right? Would we increase the FiO2 from 40 to 50? What would that do? It would increase the oxygen. Why? It's okay, we don't need to increase it, right? What would increase in the vent from 12 to 14 do? Increase in the rate. Blow off more carbon dioxide. So that would bring down that carbon dioxide and hopefully bring this patient into a normal pH. Okay? This is the application of a blood gas. Okay? This is what you will be doing in practice. You won't be sitting there all day evaluating APGs. Nobody cares. Okay? All right, so acute respiratory failure. You're going to have lots and lots of patients who have had respiratory failure. Respiratory failure is simply a definition. And it's a definition of low oxygen and or high PCO2. And just remember the number 50. Right, so if the oxygen is, the PO2 is less than 50, or the PCO2 is greater than 50, usually they happen together, right? The majority of the time you're going to have a mixed respiratory failure, hypercapnic and hypoxemic. What I'm saying here is that when the PCO2 gets to 50, you're probably going to have a really low pH. Okay? Respiratory failure is not a disease in itself. It's kind of a manifestation. It's a manifestation of something else. Respiratory failure is always caused by something else. So if your patient in the ICU had respiratory failure, and several of you have had that situation, what you probably did was you just researched respiratory failure. You should have also researched what? The trauma they had, the pneumonia, whatever is going on in that patient, the brain injury, because the patient's not breathing because of that. There's always an underlying cause for respiratory failure. Right? So to fix respiratory failure, we should treat the underlying cause. Right? Realize that when you have a hypercapnic respiratory failure, what's going on here is that you don't have enough air getting to the alveoli. You can't exchange, and you can't get rid of that carbon dioxide. Usually with hypoxemic respiratory failure, it's an actual problem with the alveoli. The manifestations of hypoxic and hypercapnic are going to be very similar, and they're, like I said, the majority of the time going to happen together. So I wouldn't give you a question that said, determine which state of respiratory failure this patient is in based on these symptoms. You know, it's going to happen the same way. So I try to be as realistic as possible. Okay? But you do see a few differences. Remember that with a person who is chronically hypercapnic, and you've learned about a patient, it's like this, that's that patient with COPD, right? Chronically hypercapnic. They compensate and they deal with it well. But as that patient's PCO2 rises, hypercapnic, it decreases mentation. They get confused and kind of tired. That's a very big manifestation of hypercapnic respiratory failure. When a person is hypoxic, they will be anxious, tachypnic. Hopefully the first thing that you assess is not what? Cyanosis, right? Because you are a bad assessor if that is the case, right? So to diagnose respiratory failure, what do we need? We need an ABG, right? Because it depends on the PCO2 and it depends on the PCO2. PO2, PCO2. And the chest x-ray can tell us if there's anything going on within the lungs themselves, infection, fluid, whatever. So mainly the treatment should be to treat the underlying cause, but also we should support this patient respiratory-wise, so give them oxygen, ventilation, whatever they need so that we can keep them, hopefully, with enough oxygen, number one, and then get their carbon dioxide down. Often that requires mechanical ventilation. Bronchodilators, remember albuterol, things like that, can help open up the airways to get that air to the alveoli, right? Because with hypercapnia, what's the problem? Air's not getting to the alveoli. Antibiotics, often infection is a problem here. Is the underlying cause. Pneumonia, whatever. We talked about the differences between impaired gas exchange and ineffective ventilation and ineffective airway clearance. So all those are in play. But I think one of the most important things for us nurses to do is to assess if the patient is improving. So what would be the best outcome? How do we know if this patient is improving if they have one of these problems? Okay. Risk for injury, cerebral hypoxia would be a really big injury, right? A person who's hypoxic is what? Anxious, fearful. I've seen so many times, I might have said this already, but when a patient is hypoxic, people don't assess that that's what's going on initially, and they get mad at the patient. And they want to yell at them and things. Lay down, we need to do. That's not going to do a darn bit of good. Okay, so if your patient is becoming acutely hypoxic, they are going to be anxious and fearful, and they will fight you. Okay, they are air hungry. They think they are what? Dying, right? So they're fighting for life. There was one situation when I was working in the ICU, and there was this young girl, and she threw an acute PE, so she was acutely hypoxic. We didn't know that was what was going on at the exact time, but we picked up on this patient is hypoxic. And there were people, one of the nurses was yelling and stuff. I stayed calm. The patient was in the bed, sitting up. I pushed the patient down in the bed. You can't rationalize with them, and I began to bag the patient with an bamboo bag. You can't say lay down so I can put some oxygen on. If they're fighting, you have to not fight back, but sometimes you have to put them in the bed and ventilate them so that they can live. Okay? So don't yell at the patient who's hypoxic. You'll look like an idiot. All right? What's going on here? Oxygenation, airway maintenance, cardiac monitoring, right? Because when a patient is hypoxic, they are going to have cardiac dysrhythmias. Often it's bradycardia, and then ends up being a VFib and then a systole. Right, so all of these are focused on treating the underlying cause and supporting the patient's respiratory system. Since day one of nursing school, I think that you've been told to keep the patient's head of bed elevated, right? If your patient is not on spinal precautions, they should be what? Head of the bed up. Okay? Make sure there are no extra secretions in the airway because we want to make sure that the air and oxygen is getting to the alveoli. Because that could be the problem. So let's look at this. Patient in respiratory failure. Patient is dyspneic, lots of sputum, and is coughing. What's the next action? Would you call for help? That's usually not the answer to a nursing question, right? That's always to do something first. The priority is not to initiate IV access. The priority here is the airway. You would also take breath sounds. Right? You have to figure out what is called. Is the patient wheezing? Does the patient have bronchi? Does the patient have breath sounds? So you need to know what you need to do because if the patient has bronchi, a bronchodilator probably isn't going to do a lot, right? If the patient's wheezing, then we need a bronchodilator, right? So you need to assess what's going on here. And generally, and probably in Adult Health 1 you were taught always, never about this, to never give a patient with COPD more than 2 to 3 liters of oxygen. That is absolutely not true. Okay. If the patient needs the oxygen, you give them the oxygen. Okay. I've seen many times a COPD patient on a non-rebreather. theory, that's 100%. It's really not 100%, but you don't want to send them home on 5 liters of oxygen because they will go home and stop breathing. Okay, but when they're in the hospital and they're attached to a monitor, and we're going to pick up if they're not breathing. Okay, so they can be closely assessed in the hospital. So just keep in mind, if a patient needs oxygen, they are in the hospital, they are hypoxic, give them oxygen. If it's ordered, don't question the doctor's order because they ordered 40% FiO2 for a COPD patient. They will cut you out and hang up on you, right? So if they need it, they need it, okay? That whole theory is that they don't go home on more than 3 liters of oxygen. And the reason is why? Right, yeah, so hopefully no one in this room has COPD, whatever. But so all of us, right, what drives our respiratory rate? The level of CO2, right. So, but a person who is in COPD has what? Chronically high CO2. That doesn't determine the respiratory drive anymore. It's the level of oxygen. So if we give them plenty of oxygen, like, oh, I don't need to breathe, I got plenty here, right? So there you go.
Can you explain why it's not initiate oxygen by nasopharyngeal liters?
Because you need more assessment here. You need more assessment. You need to figure out what is causing this problem. It doesn't say that the patient is hypoxic. Yep. If that said assess SpO2, that would be the answer.
Mr.
Yes, ma'am.
Spencer, is that in line with the ABC's airway breathing circulation?
Well, yeah, this is an airway. Where am I? This is an airway problem. Yeah. So it talks about respiratory failure. That's simply when the PO2 is less than 50, the PCO2 is greater than 50. Usually happens together. Usually caused by something else. Well, we can have actually extremely bad respiratory failure, and this is called acute respiratory distress syndrome. This person is extremely sick. ARDS. Pulmonary edema happens here, but just understand that the pulmonary edema is happening not because of a cardiac problem, it's a respiratory problem. We'll talk more about why. The number one cause of ARDS is sepsis, is infection. Trauma is another big risk factor for ARDS. ARDS usually develops within 48 hours to 72 hours after the initial insult. So after the patient becomes septic, usually within a few days, that's when they're going to become in ARDS. We had a patient yesterday that was in ARDS. We diagnosed it. They hadn't diagnosed it yet, but I'm pretty sure that patient had ARDS. But what's happening here is that there's a lung injury from some cause. Usually it's infection. Okay, infection is in the blood, and it is affecting the systemic inflammatory response system. We talked about this in septic shock. What you're going to notice is that septic shock and ARDS have a similar patho, but they're just happening somewhere else. So you're going to see that. So you have an infection, probably. You have a systemic or an exaggerated immune response. And in septic shock, what happens is that the vessels are damaged, right? They leak, they dilate. Here, what happens is the alveoli are affected because the problem is affected. The lungs are affected by this. Those capillaries around the alveoli become more permeable. They leak. Fluid gets into the alveoli. The inflammation is happening in the alveoli. When you have inflammation and infection, your immune system releases white blood cells and all of these things that cause scar tissue. The surfactant production is decreased because of this situation, so therefore we can end up with atelectasis. And because of the scar tissue that is happening due to all of the inflammation and infection in this area, the lungs become what we say stiff. They don't become as pliable. They can't expand normally like ours and fill with air easily. So this person has a severely, really bad impaired gas exchange problem, right? Why? Because there's probably fluid in the alveoli. The alveoli have collapsed. So we are not exchanging gases here. What does that say under there? Refractory hypoxemia. That's important. So refractory hypoxemia is the hallmark sign of ARDS. And I'll talk about what that means. I said 24 to 48 here, but whatever. Short period of time. So early signs are those of respiratory failure. And then later we have more severe signs. The person develops respiratory failure. This person is probably 9 times out of 10 going to require ventilation. This is extremely important. I even put a star by it and didn't even require you to do it, so maybe you should underline it too. But understand why the patient has refractory hypoxemia. What refractory hypoxemia means is not that the oxygen goes down when you give them oxygen. It just means that it doesn't fix the problem. Why? It can't get there, right? It can't get to the alveolar where it needs to be, and that's where gas exchange happens. So you can give them all the extra oxygen you want, and you're going to see little to no change in the oxygenation level. That's refractory hypoxemia. And that's happening because you learned in the patho that the alveoli are full of fluid, blood, collapsed, whatever. What that is a manifestation of is a ventilation-perfusion mismatch. And we'll talk more about that too. So the diagnosis of ARDS it's a lot of different things, but generally this is what it is. The patient has a low PF ratio. What that means is the P stands for PO2, and the F is the FiO2, PF ratio. So what we calculate is the PaO2 on the blood gas divided by the FiO2. And you remember, if you have a percentage, you can't work with it. So if the FiO2 is 50%, you would divide by 0.5, right? Way back to those, right? So the lower this number, the worse off the patient is. Us in this room, we have a PF ratio of 4, 5, 600. But the person who has ARDS has a low PF ratio because what this reflects is that we're giving them extra oxygen and their PO2 is not responding to it. So if you gave me or you 100% oxygen, our PO2 would rise to probably 3, 4, 500. Okay? We just want it to be about 90, right? If you give a person supplemental oxygen and their PO2 elevates, that tells us that the alveoli are working, right? So this person's alveoli is not working, so therefore we're not going to get an increased oxygen level when we give them extra oxygen. Also on the chest x-ray, you will see, or it is seen that there's a whiteout pattern, and what that means is I talked about pulmonary edema. That essentially is what is happening here. But remember that air is nice and black, and anything else is usually white or gray. So this patient will have diffuse, meaning all over, infiltrates on the chest x-ray. So this patient's x-ray will look relatively white, which is really bad. Is the alveoli full of fluid or collapsed? Decreased lung compliance, remember that's because the patient has stiff lungs. They're not expanding as they should. They're full of fibrous tissue and fluid. So on the ventilator, what you would see is the patient would have elevated peak pressure, right? Because the machine is meeting higher pressure to get the air in because the lungs are, quote, stiff. When you blow a balloon up, what is one of our first instincts to do when we do that? Stretch it out, right? We're decreasing the PIP, right? Decreasing the resistance that we meet to blow the air in there. And because the lungs can't expand, the total lung capacity decreases. If they can't inflate, then we can't get as much air in there. So you see, this person's X-ray doesn't look really good, but they still have some white or some black. This person has diffuse bilateral infiltrates. They probably looks like they maybe have heart failure. That's a big old heart. Here's a pulmonary artery catheter. See it? This is probably that's probably the black lead.
Can you real quickly go over the high peak pressure again real quick?
The high peak pressure is because the lungs are stiff and not pliable. They're not easily blown up. So if you try to push air into something that is not pliable, it takes more pressure to get it in there. And that's what the PIP reflects. PIP. Peak pressure.
The peak, the same thing as the PIP.
Yes. Peak is PIP. Peak inspiratory pressure.
But I know that some people just call it the peak.
Right.
But that's okay, they're interchangeable.
Yes.
Okay.
Again, because this is a form of severe respiratory failure, it's not a disease within itself. It's caused by something else, probably sepsis. So what we want to do is treat what's going on with this patient. So they're going to need antibiotics, probably, lots of respiratory support. And on the ventilator, these are the settings that you're going to see. They're probably going to have high FiO2. Try to maximize the oxygen that they get. If they're getting a little bit of ventilation because they have alveoli, we want it to be very saturated with oxygen so that it does some work. The rates will be elevated, and the tidal volume will be low. The tidal volume is low. Why, Chris? You just said it. Can't get a lot of air in there. It's stiff, right? So if you try to push 700 milliliters of air into this person's lungs, what's going to happen? Pneumothorax on both sides, right? It's going to blow their lungs out. And the rate has to be high to compensate for that low volume. So you have to breathe more. We call that minute ventilation. It's more advanced. You don't know it. But so you have to breathe more to get that exchange because it's a lower volume. High FO2, high rate, high PEEP, because the alveoli are extremely sick here. They need a lot of pressure to stay open. Remember, that's what the PEEP do. The PEEP does. Keeps the alveoli open. Maximizes oxygenation. So you'll just remember here, high FO2, high rate, high PEEP, but low tidal volume.
Which is basically more ventilation because they can't hold.
This is maximum respiratory support.
So supposed to be low P and PIP, right?
PIP is not a setting.
Okay.
So what?
If you see it on the
Measure.
screen.
It's probably going to be high. But we don't want it to be too high because we're at an increased risk of having a pneumothorax. So the peak pressure, the PIP, is elevated. They will probably continue to lower the tidal volume so that we don't have as much pressure. We're not trying to put so much in there. So that low number will come down. We want to not over-hydrate this patient because what's the problem here? Fluid has shifted to the alveoli, so we want to keep them a little bit dry if possible, which is hard to do because hopefully we will kind of hemoconcentrate the blood a little bit and hope that some of that fluid will shift by osmosis right back into the vasculature. Nitric oxide, not nitrous oxide, nitric oxide is a compound that is inhaled and it causes vasodilation. Because it's inhaled, it causes vasodilation in the lungs of the alveolar capillary beds. So hopefully we can get more gas exchange if we dilate those capillaries. It works. And you can remember that because, nitro, right? Nitroglycerin, nitric oxide, vasodilation.
That's like nitrous oxide you breathe in the dentist.
That's nitrous oxide, yeah. And it's one of those things that bothers me that shouldn't, we all have those things. Then when people call it nitrous oxide, it's not nitrous oxide, it's nitric. It's a totally different molecule. Okay? But whatever, I just let them say it. Bronchodilators, right? That's like albuterol. Atrovent is an anticholinergic. They work a little bit differently. I'll think about it this way. Bronchodilators actively cause bronchodilation by agonizing the beta receptors in the lung, right? But Atrovent is a what? Anticholinergic, and it actually prevents bronchoconstriction. But we give them both often together. We call it an ANA.
You substitute atropine with Atrovent?
No, because Atrovent is inhaled.
Okay.
Yeah. But it is in the same class as anticholinergic. Yep. So good point. Keep that in mind.
You give those around the clock.
Do what?
You give those around the clock.
Sometimes patients will have continuous respiratory treatments. But yeah, and if it's not continuous, sometimes it's Q2 hours. Usually the respiratory therapist does those things especially if it's nebulized. But if we use an MDI, we can do an MDI on the vent. I'll do those, but I'll let the respiratory therapists. And usually they are thankful for that because they have a lot of patients, and every 2-hour breathing treatments is a lot of work. But very frequently, you're right. Surfactant therapy. The patient has altered surfactant. It's not working. Remember the action of surfactant to keep the alveoli from collapsing. So we can actually, it's very rare that it's done. I've only seen it done when we've done some studies on it, that they actually put synthetic surfactant into the breathing tube. It's a foam kind of. You put it in there and it goes down. Hopefully it works. But that's a possibility. Nutrition, make sure the patient has lots of protein for healing, right? And prone therapy. Prone therapy is this contraption here that looks real scary. And prone therapy means what? Patient's lie prone, face down. So this is used fairly frequently in patients with ARDS. Some people feel like it doesn't work. Some people think that it does work. Different research says different things about it, but I've seen it save people's lives. So the patient would lie inside of this, so these buckles would cover up the patient. So the patient would be within there. So their feet would be at this end. Their feet wouldn't stick out, but their feet are down here, and their head is this thing right here, which you can see looks kind of like R2-D2. This goes over their face. So the breathing tube would be sticking out. There'd be lines everywhere. Ventilator back here, Foley, chest tubes probably, SCD machine. Things are everywhere. So I love taking care of patients. So what happens is that often we have to paralyze this patient. Somebody said paralyze me. This patient needs lots and lots of sedation and lots of pain medication and often a paralytic, a drip. But what this machine does is that it rotates. It's a roto-prone. So the patient, we would put them on it, of course, upon. And then on this little touch screen down here, we set it, and it will flip them over, and it puts them face down. It doesn't go all the way around because then everything will get all tangled up. But the patient goes. It doesn't go 360. But yeah. But yes.
Yeah. If you put a patient in there with acute respiratory
areas,
is that only to get them through that point, or is that for a chronic person?
No, this is acute and short term. Yep. This should be initiated early in ARDS. What usually happens is that they use it as a last ditch effort. So often people go on this bed and don't come off of it, but I have seen this bed save people. It's everything. But this bed really can do good. But the reason that prone therapy is beneficial is because when we're standing or lying on our back, what part of the lungs are perfused the most? So if I'm standing up, what part of my lungs are being perfused the most? The bottom, right? Think about gravity. So if the patient is laying flat and the head of the bed elevated, it's the back and the bottom, right? But if you lay a person face down, what is the most perfused area of the lungs in? The anterior side, which is it's not utilized as much because of our positioning. So they call it recruiting alveoli. So they're trying to use those alveoli that aren't used as often, and hopefully we'll see an improvement of their oxygenation. It works, but sometimes it doesn't. All right.
So you had to sedate the patient?
Have to be sedated.
Okay, so what else do we need to assess? Like,
Skin is a big thing. So the patient has an increased risk for skin breakdown. The patient has an increased risk of corneal abrasions because of that face pack. So you have to make sure that their eyes are closed because that can easily slip over and touch the eyes. So they have an increased risk of corneal abrasion.
So how long do they normally stay in the machine?
It could be just for a day or two, or it could be for a week or so.
So it's easy access to.
Yeah, because these buckles, these are seat belts right here, and they unbuckle, and this is one piece. See, and it folds all the way out, and you can actually hook it up under. This one will fold out and you hook it under. So you can get to your patient. And one of the reasons why, these beds are a little easier than some patients, I guess, that are not on it, is because they have a bowel movement or something. I just flip them prone and lay them from the back up. Because on the back of the contraption are big doors, so if you put them prone, you can open up the back door, and then and there's the back of the patient. So if the patient is hyperthermic, sometimes we'll just put them prone and open up the back doors, and then they get airflow. Yep.
Does this replace their bed? Are they in their room, or is there another area?
That bed is taken out.
Okay. And the other question, the corneal abrasion thing that you said, is that? Can you explain?
Yeah, because see this mask right here?
Uh-huh.
So this goes to the face, because if they're put prone and their head's not supported, their head's just going to hang down. So there's these little slots right here which you can't really see, and that's for their eyes so that it doesn't touch their eyes. But it's small and it can move, and the patient shifts and it can rub their eyes.
Okay, so the mask rubbing their eyes if their eyes aren't closed. Okay.
Yep. Let's see. Let me go back to this. So understand that this alteration in PF ratio reflects that the patient has what we call a ventilation perfusion mismatch. So in order for us to have optimal gas exchange, we have to have adequate ventilation of the alveoli, right? And we have to have adequate perfusion of the capillaries that surround the alveoli. For the entire respiratory cycle to happen, for respiration to happen, you have to have proper ventilation to the alveoli and proper perfusion of the alveoli. So when you have a ventilation perfusion mismatch, one of those two things is not happening properly, so therefore you're not going to have what? Proper respiration. Right? In ARDS, generally what is happening is that you don't have ventilation of the alveoli. Why? They're stiff and full of fluid, right? The air can't get to it, the capillaries, because there's fluid in the way or they're collapsed. All right? Ventilation perfusion mismatch. That's why the biggest problem in this is impaired gas exchange. Okay? I'm not going to read those to you, but I think you understand them. This person needs to conserve as much energy as possible, because by doing things and moving, and we're doing what? Using up oxygen. So this person should be, we should reserve or conserve as much oxygen as possible in the patient who has ARDS. We talk about suctioning and how we should only suction when indicated, but especially in ARDS, because the more suctioning you do here, the more trauma you're causing to the lungs, the patient may cough, and that increases their risk for a blown lung. Okay? We don't want that to happen. So suction very cautiously and conservatively. Yep. We can beat on their chest and keep their head up to help promote drainage and expansion of the lungs. If they're not laid prone, So Halen was jumping ahead and asked me about this question in the right way. So read this question. So the patient is going to be given Atrovent. An allergy to which of these medications would cause you to question that order? So this tells you that you have to know what is the classification of Atrovent. And we said it's a what? Anticholinergic. So therefore, what's the answer? Atropine. Because atropine is an anticholinergic. Right? Seems very straightforward and easy right now.
Yeah.
Right?
So you say the Atrovent is inhaler. Atropine is not inhaler form, but will you give Atropine to
Not usually. Usually in an acute situation, atropine is given to increase heart rate.
Okay.
Atropine can be given in other situations. You probably learned in mental health that you can give it before ECT, dry up secretion, things like that. Because what is one of the side effects? Can't spit, right? So, dries up stuff. Lots and lots of medications have anticholinergic side effects. One that we use often every day is antihistamines, right? And an "-ine", right? It's an anticholinergic. All right, let's talk about chest trauma. Chest trauma is one of the causes of ARDS, but chest trauma generally happens because of a blunt chest injury secondary to a motor vehicle accident. The steering wheel is a big culprit here, right? The seat belt is a big culprit here. This seems maybe not significant, but it is. 25% of MVAs cause death in elderly people. Usually you think about elderly people just dying because they're old or they have diabetes, something like that, but MVAs are a big killer of old people. So chest trauma, we have two types in general. Not two types, a few. So we have penetrating and non-penetrating, basically, and then acceleration, deceleration. So blunt, non-penetrating basically means that the chest has been struck and there hasn't been penetrated. There's not a stab wound, there's not a gunshot wound, it's closed. Rib fractures may happen, right? In a penetrating chest injury, the chest wall is open. There is communication between the environment, the atmosphere, and the pleural cavity and lung. Usually this is a knife stab wound, gunshot wound, penetrating injury. Maybe they fell on something out of a tree and they hit a branch and it went through their chest. It happens all the time. Fell out of a deer stand, all the time. I bet somebody here knows somebody that fell out of a deer stand. Because what do people do when they go to deer stands? They drink. And they get clumsy. So, and they shoot guns. Yep, and fall out of a deer stand. Yep. So, anyhow, that's it happens all the time. Is what I said. So often, because there is communication between the atmosphere and the pleural cavity, we'll call that sometimes a sucking chest wound, because the air is moving from the atmosphere into the pleural cavity, and it sounds like a sucking sound, and it's air moving in between the pleural space and the atmosphere. The sucking chest wound. Right? It's a penetrating chest trauma. Acceleration, deceleration is a type of non-penetrating injury, and this happens because you have maybe a car accident, and inside of the chest, everything kind of sloshed around and caused injuries within. Sometimes, or this happens in the head too. It's called a coup contracture injury. But so.
Isn't that what happened to Princess Diana?
Huh?
She had the acceleration, deceleration.
Well, I think she was really beat up pretty bad. I don't know. I think it was going 100 miles an hour, and she didn't have seatbelt. So her brains were still. You'll see it one day. Brains on a bed.
We'll say that.
So rib fracture can happen because of a chest injury. Sometimes something as simple as a fall, a same level fall. You fall and you hit the table, rib fractures. Especially in old people, this is a big problem. This is just an FYI, ribs 9 to 4, most commonly because they're less protected. A big problem in a rib fracture is that the pain is causing an exacerbation or further problems with this patient, because we want this patient to breathe deep and expand, keep their respiratory function optimal, but it hurts to breathe, so they have an ineffective breathing pattern because of that. And eventually we'll have impaired gas exchange because of decreased ventilation. They're not breathing deep enough, so atelectasis can happen. So shortness of breath, pain, splinting, guarding of the area, not breathing deep, ecchymosis, is bruising on the chest wall. Crepitus, remember, is that feeling of subcutaneous emphysema, right? You might have thought that those things were the same thing, but they're really not. One is a manifestation of the other. Crepitus can be, you feel it on the joint, because the joints are rubbing together. But it's a feeling, it's really hard to describe, but you can kind of think about a beanbag or a hacky sack. You feel that. That's kind of what crepitus feels like in the subcutaneous.
What can we assess it? How can we assess?
You palpate this.
Okay.
It's a sensation you feel with your hand. Diminished breath sounds because the patient is not breathing, right? They're not breathing deeply, so they often will have decreased breath sounds specifically in their faces. Because the person is not breathing, coughing, and things, and probably not moving a whole lot, there are these risk factors, pneumonia, right? They're not expectorating, coughing. Atelectasis, that's collapse of the alveoli because they're not ventilating those alveoli, so they collapse. And that can lead to respiratory failure. So anytime that I have a patient, I've mentioned Pneumo a couple of times, I think. Anytime you have Pneumo come in to the ER, you fell in the bathroom, put your chest on the bathtub, you got 6 rib fractures. Oh, Jesus. You know, she's 80 years old. To me, that's really, really bad because usually old people, I call them a ticking time bomb if they have rib fractures. They're not going to breathe deep. They're going to be ornery. They're not going to want to move around. They're not going to use their incident spirometer. They're going to end up going into respiratory failure. So, prevent your Pneumos from falling, okay? Because they're fragile. You know, little old lady, she probably has osteoporosis. So, those ribs are very fragile. So, just be careful in your patients that are especially when they're older, that if they have rib fractures, it's a simple injury, but it has big time complications. You want to prevent those. So we want to make sure that they don't have a lot of pain, control their pain as much as possible, so they can do what? Breathe deeply, not have pain while they're breathing. Promote deep breathing. Okay. A nice thing that we can do is use this thing called an on-cue ball. And this is attached to a catheter, and the catheter is placed in the muscle or the subacute tissue surrounding that rib fracture. So the analgesia, and often they'll use bupivacaine, like lidocaine, and it numbs the area. So it's very good. It puts the analgesia right where it needs to go, and they don't have systemic effects because it's not absorbed. It's not in the bloodstream, right? Very good. They're very expensive, but they work well. But we can also give morphine and Percocet and things like that. You've always learned up until now, be very careful with these narcotics because they will depress the respiratory system. So you would not give this to this patient, but you won't want to give them too much because there's a careful balance here. So don't over-medicate your patient with IV or PO narcotics because it suppresses their respiratory drive and you're just going to cause more problems. Teach them how to splint, so give them a pillow, put on that area, because if they splint and hold that pillow toward that area, it kind of keeps it still and doesn't cause as much movement, which can cause pain. Anxiety. Yeah. We'll talk about a pneumo and a hemothorax probably next time, unless it's just next, and all of those things. Okay? Another thing about splinting, you teach them to splint, and maybe in the past you've heard this or even probably seen it, is that the person with rib fractures, you give them a chest binder. That's not good practice. It's not good practice. Why? It doesn't allow them to expand their chest. It does help a whole lot with pain, but it defeats the purpose, right? They still can't expand, and they are going to have an increased risk of those respiratory complications. Here's a question. Patient came to the ER, they had rib fractures. What would we teach them to do? Would we teach them to avoid pain medication because it depresses your skin? No. So be careful with it. Don't take too much, right? Would we tell them to use a chest binder? I just told you no. Now, you can't get out of the bed for at least a week. Absolutely not. They need to be walking around, right? And D is the best answer. Use a pillow to splint when coughing. It decreases pain, and it's intermittent. Oh, yeah, flail chest is next. So flail chest is usually happens, or not, but it happens when there are 2 or more fractures of ribs in an area. 2 or more ribs fractured in an area. Often what happens is that a segment or an area of the ribs is broken away from the rest of the chest wall. So therefore, that results in a free-floating chest wall segment. Okay, so, and I'll show you what that is in a minute. So, the chest wall provides not a barrier, but a firm encasing around the lungs and helps with ventilation. It maintains the pressure inside the chest. But when you have this segment of ribs that are free-floating, that inhibits or compromises that chest wall stability. So the patient is at increased risk for lots of complications. The free-floating chest wall segment will do what we call a paradoxical chest wall movement. So normally when you inhale, your chest gets bigger, all over nice and even, right? When you exhale, it gets smaller and shrinks. But when the person that has a free-floating segment, they have paradoxical movement in that when they inhale, that segment is sucked in, and when they inhale, it's blown out, right? Because remember, when you inhale, it creates what in your chest cavity? Negative pressure, so it sucks that thing in there. And when you blow out, it's positive, it's kind of passive pressure, and it passively flows out, but that segment that is broken away will protrude. Lots of pain, and this person is unable to effectively clear secretions, and this is because they don't have that stable chest wall. So when they cough, all of the pressure and expectoration should normally happen out of the upper airways, but where does some of that go? Out of that free-floating segment, right? That pressure goes here, so they can't effectively get enough pressure up through the upper airways to expectorate. So that's a big, big problem.
Where does it go?
Where does it go? The pressure just goes out there. The volume will eventually move out of the airway, but when you cough or sneeze, it's a fast exhalation, lots of pressure that comes out. And that pressure goes out of the chest. The lung goes out. Yeah. So this can be a big problem. This person, sometimes they can compensate, sometimes they don't compensate very well. So the way this is diagnosed is simply by seeing it, feeling it, and also, of course, a chest X-ray is going to show that it can fractures. Alterations in respirations, hypoxic, lots of pain. They could go into shock because they are hypoxic. Crepitus again, bony crepitation, so you can feel crepitus because bones are grating together. Right? Increased secretions, draining, because they can't expectorate them. So you may have increased secretions in the airway when you suction because the patient can't get them out. And they're tachycardia. So our priority is to maintain the respiratory function, make sure the vital signs are stable, and to make sure that they have a patent airway because they can't effectively and independently expectorate secretions. We might have to suction for them. If the patient is compensating fairly well, they may not need anything other than a little bit of extra oxygen and some pain medication. We can also give them intermittent positive pressure, and that's just kind of like a mask with a little extra pressure. Like I said, if the patient is unstable, meaning that they are unable to maintain a normal oxygen level or tachycardic respiratory distress, this person must be intubated and mechanically ventilated. The treatment for unstable flail chest is intubation and mechanical ventilation. A thing that can be done in the short term is to manually stabilize that segment. So you could either put your hand on it so that it doesn't protrude when the patient exhales. You can kind of stabilize it with the hand. Or the patient could be turned onto that side so that the pressure of the bed or whatever below them is keeping it more stable. But usually, you're not going to want to turn a patient on their side when they're employed. You want to set them up. So maybe a binder or something like that, acutely, or your hand. So but stabilize the portion of the chest that has having the problem there. ABGs, of course, breathing, vital signs. Okay. The patient may have bleeding because of all these broken ribs. There's lots of vessels in the chest, so they could have bleeding because that bone is moving around and can compromise some vessels. I'm going to show you this video. Hopefully it works. Maybe you already watched it, but if you didn't. Can you see it? Right here. So when he breathes in, it sucks it in, right? When he exhales, it's blown out. So this person is probably compensating okay because they haven't intubated him yet, right? He's just got some oxygen. So that's the free-floating chest wall segment, right? Flail chest. Okay, so read this question. It's long, isn't it? A lot of information. Patient had an MVA, poison in MVA, motor vehicle accident, right? They were unrestrained, not good, right? The mentation was obtunded. Y'all know what obtunded means? Decreased mentation. Respiratory rate was high, SpO2 was low, and it's low even though we're giving them 80% oxygen. Not a good situation, right? This patient's not doing well. So the nurse has also assessed bony crepitation and instability of a portion of the chest wall. What's wrong here? Flail chest, right? But more specifically, what kind of flail chest? Compensated or non-compensated? This person is not compensating very well, right? So what is the treatment for uncompensated or severe flail chest intubation? How many slides are left in respiratory? Not pages, slides. We have how many? 15 minutes? Let me see if I can get through pneumothorax. Okay, so pneumothorax. There's different types of a pneumothorax. In general, pneumothorax is air in the pleural space, causing compression of the lung. You can have an open pneumothorax, and that's also, we learned, that's a sucking chest wound. So there's air moving from the atmosphere into the pleural space, often because of a rib fracture or something like that, or not a rib. It could be a rib fracture because a rib can actually come out and penetrate the environment, or we can have a stab wound or something like that. But so the air is going into the pleural space. The pleural space is a cavity around the lungs that helps with movement and lubrication and easy movement of the chest, of the lungs. But if there's only a very small amount of fluid in the pleural cavity, so there should be nothing else there. So if we get too much air in there, it's going to push against the lung. So that portion of the lung where there's that pneumothorax can't expand. Is this the first slide? Yeah, okay. So when you have an open pneumothorax, the air comes into the pleural space but also exits the pleural space. Okay, so because it's the sucking chest and the air is moving back and forth between the environment and the pleural cavity. That can cause a mediastinal flutter. So during inspiration, the mediastinal structure, just a fancy word, right? The middle here, trachea is what we can easily assess. It's in the mediastinum, is shifted. So just know that the mediastinum shifts back and forth during respiration with the mediastinal flutter. Flutters back and forth because the air is coming into the pleural space and exiting the pleural space. And the mediastinum is shifting over because we're having air that doesn't belong there pushing everything over to the unaffected side. Right? Does that make sense? Number one signs of pneumothorax, dyspnea and tachycardia. Also, decreased to absent breath sounds over whichever part of the lung is affected, because if it's collapsed or compressed, air's not going to go in very well, so you're not going to hear any lung sounds over the affected area. Perhaps chest pain too. The treatment of a pneumothorax is generally a chest tube. We can also do a thoracentesis, and this is a more temporary thing where we go in, pull out what we need, and then the needle comes out. And of course, support of the respiratory system, right? Oxygenation if they need it. Another type of pneumothorax is a spontaneous pneumothorax. Often a spontaneous pneumothorax is caused by weak areas in the lung. This sometimes for some people is a chronic problem. They have what we call blebs on the lung. It's a weakened area. Think kind of like a hernia on the lung. And that sometimes will blow, especially with coughing. If they get sick, the bronchitis or coughing a lot, they can blow out that bleb and end up with a spontaneous pneumothorax. So there's no external wound, and therefore we would call this a type of closed pneumothorax because the air is not exchanging between the pleural space and the atmosphere. It's staying within. Often with this spontaneous pneumothorax, sometimes it can be tension or it may not be tension. So spontaneous without tension means that the air goes into the pleural space but doesn't get trapped there. It can make its way back into the lung from the pleural space. So it can move back and forth between the lung and the pleural space. Remember that when you have an open pneumothorax, you have air movement between the pleural cavity and the atmosphere. But with this closed, spontaneous, you have movement between the lung and the pleural cavity. But it goes back and forth. So it's not as severe as a tension pneumothorax. When you have a tension pneumothorax, you for some reason have injury to the chest wall. You have a closed, usually it's a closed pneumothorax, can be open. But the key with this is that the air that enters the pleural space gets trapped there. So with each inhalation or exhalation, whenever the air is getting into that space, it can't go back from where it came from. So it gets trapped. There's tension there. So the air gets stuck. So therefore, maybe with each inspiration, there's more air put in there. So it gets worse and worse just by the patient breathing. It can't make its way back into the lung or out into the atmosphere. That's tension pneumothorax. The air gets trapped. So this is the most severe type of a pneumothorax because there's lots of pressure. It shifts over all of the chest structures. It can decrease cardiac output because it increases pressure in the chest cavity. Shifts the heart, the lung over, trachea over. So with this, you would have a mediastinal shift. Shift meaning that it's over and it's not coming back. It's stuck over there. A flutter means it goes back and it comes back because the air comes in but then escapes from that pleural cavity. Distended neck veins because you have increased pressure in the chest, so decreased venous return to the heart, so you have those distended jugular veins. Of course, again, with the pneumothorax, decreased to absent breath sounds over the affected area. Chest tube is what this patient needs. For an open pneumothorax, if there's air going between the atmosphere and the chest cavity, we can try to dress or put pressure on or put our hand, whatever, on that area so that it's not pulling air from the atmosphere into there. So we kind of seal it back off like it should be. And the patient, and you will have patients that have acute pneumothoraces in the hospital. You stay with them. Remember, when the patient has respiratory compromise and they are anxious and all those things, you stay with them and call for help. Don't leave your patient if they're having respiratory distress. signs and symptoms of tension pneumothorax. It can shift from a non-tension to a tension. Head to bed up, chest tube. Maybe they need to be intubated if they're not compensating well. Thoracentesis, maybe. Antibiotics, why? Because the skin is compromised if it's open. Our biggest responsibility surrounding this is management of the chest tube system.
That's the nurses.
Yes, management, not insertion, management. Some nurses put them in, they're called CRNAs, nurse practitioners. Not always. Real quickly, I won't talk about chest tubes, obviously. So hemothorax, a pneumothorax is air causing the problem. Hemothorax is blood, right? Usually blood, it can be fluid. With pneumothorax, sometimes you have a little fluid. So hemothorax, you think about blood that has entered the pleural space for some reason. Maybe that patient had chest surgery, chest trauma, the vasculature in that area has been compromised, and they are bleeding into the pleural space. So the blood fills the pleural space and compresses the lung. Manifestations are about the same, but you can also have manifestations of hypovolemia because they're losing blood, right? They're not bleeding out, but they're bleeding internally, and that blood is leaving the vasculature, the vasculature, and therefore they're hypovolemic. So they might have signs of hypovolemic shock if it's severe. Usually it's going to need a chest tube, but a thoracentesis can be used if it's chronic or not a huge problem. Also, we need to figure out what is bleeding and if it can be fixed. Right? Same thing, really, with the nursing care for pneumothorax, or for a hemo and a pneumothorax is about the same. But you want to also focus on that fluid status and assessing for the patient where they're bleeding from and their risk of bleeding. Do they have an elevated PT, PTT, INR, all those things? Is there red blood cells hemoglobin low? That shows that they're bleeding. Right. Low platelets puts them at increased risk for bleeding too.
Mr. Sasser, will you see that? I mean, will they have bruising and stuff in the chest?
They can, yeah, because it can be caused just from a blunt chest trauma. And there's a rib fracture, and that rib has made its way into there, and the way that it's situated, the rib has punctured, and it has caused bleeding. Yeah. My brain quickly went to tension pneumothorax for some reason, but yeah. So it's in a trauma, and they're bleeding.